The penultimate speaker for our morning session is a clinical and research physiotherapist. But don't think about heat packs or ultrasound. This is the only physio to have been appointed a Nuffield Medical Research Fellow at Oxford University. This year he was appointed Professor of Clinical Neuroscience and at the University of South Australia's inaugural chair in physiotherapists, the author of 90 scholarly works. He was judged by the International Association for the Study of Pain to be the most outstanding mid-career clinical scientist working in a pain-related field. Believe it or not, he just gave the opening address at the 16th World Congress of Physical Therapy, one of the highest honours in the profession. Please make welcome the physiotherapist's equivalent of Dr. Phil, Professor Lorimer Moseley, telling us about the role of the brain in chronic pain.
Thank you. Good morning. Tough crowd. Okay. I'd like to explain that I don't normally have a moustache, but I am campaigning for Movember for men's health. And I felt very self-conscious about my moustache until Jeffrey got up here. He's got a beauty. I think Craig's campaigning as well, but he's not growing it quite as well as I am. Right. Pain is supposed to be a very laborious topic, and neuroscience is supposed to be very intimidating. So I'd like to tell you a couple of stories that hopefully will summarise how pain actually works. And the story relates to my own life. And about 7 years ago, I was camping in the bush. I was wearing a sarong. Just how cool am I? And I want to reenact what happened. All right? It was early in the morning. I put on my sarong, and this happened. Did you see that? Oh, hang on. So I put on my sarong and... Now, biologically, I want to tell you what happened just then. Something touched me on the outside of my left leg in the skin. That activates receptors called Paxinian corpuscles. And they sit on the end of big, fat, myelinated nerve fibres, and they send a message straight up my leg, straight into my spinal cord, up to my brain, right up to here, and they say, "You've just been touched on the outside of your left leg in the skin." They're really fast. Meanwhile, whatever it was also activates thin, unmyelinated, slow-conducting, Lada-Neva type nerve fibres. Does anyone know a Lada-Neva? It's a car you should never buy, nor inherit. And the message comes up and it gets to your spinal cord, and that's as far as it gets. And that message is, there's danger on the outside of your left leg in the skin, mate. They're Australian nociceptors, right? And then that activates spinal nociceptors, which take exactly the same message to your brain. And that message got to my brain and it said, brain, yeah, thalamus I'm interested in. Thalamus, there's danger in the outside of your left leg in the skin, mate. And the thalamus, which is like the relay station, says to the brain, I've got something for you here. There's danger in the outside of the left leg in the skin, mate. Now, the brain has to evaluate what this actually means. And in a split second, outside of my control, outside of my awareness, the brain calls on the frontal part of its organisation and says, any information I should know here about previous experience? The parietal cortex, which says, yes, where are you? You're in the bush, you're walking, you're at that stage of your gait cycle. Frontal cortex, anything particularly relevant to that? Yes, actually, growing up, you always scratched yourself on twigs walking through the bush. This is not a dangerous situation. You've been here 1,000 times. In fact, I might just give... Okay, let's give you the experience of something so you can kick off that twig and keep walking. And that's exactly what happened. My brain made the conclusion, how dangerous is this really? Well, thanks, spinal cord. Appreciate you letting me know. But it's not that dangerous. And I kept walking. And I got to a river. I took off my sarong and I had a swim. Then I got out and I started walking back to where I was camping. And that's the last I remember. Apparently then I started to stumble and I vomited, and 4 days later I woke up being the first Anglo-Saxon survivor of the eastern brown snake grade 3 bite. Thanks very much, it's been great. No, that's not true. So in actual fact, my brain made an erroneous conclusion and said, based on what I know, how dangerous is this really? It's not dangerous at all. 9 months later, having survived the second deadliest snake in the world, actually it's now the third deadliest, they've found another one, but I survived the second deadliest. And this is what happened. I was in a conversation with a boring talker. You all know a boring talker, don't you? You know those people, it doesn't matter what they say, it's boring. Maybe you're sitting next to someone now and you should say, okay, you're my boring talker. Anyway, I was in this conversation with a boring talker, walking in the bush, some very fashionable King G hard yakka shorts on, and this is what happened. I'm always embarrassed reenacting this, so I apologise now, but yeah, right. Oh! And I swore, which I don't want to do now. Biologically, I'll tell you what happened. Something touched the outside of my left leg in the skin. That activates big, fat, myelinated, fast-conducting A beta fibres up my spinal cord. This is straight up to here, and that says, just be touching the outside of your left leg in the skin. Whatever it was is dangerous enough to activate thin, unmyelinated C fibres, we call them nociceptors. Takes a message to my spinal cord, and it says, danger in the outside of your left leg in the skin. Well done, Sydney, that's fantastic. The message goes up to my thalamus, and the message says, thalamus, I've got something for you, danger on the outside of your left leg in the skin. The thalamus says to the brain, sorry to disturb you. Yeah, not too bad. No, they're good. Yeah, okay, yeah, struggling with maths, but that's okay. Anyway, whatever. There's danger in the outside of your left leg in the skin. Now the brain goes, thanks, thalamus, spinal cord, I appreciate that. Let me just evaluate everything here. Okay, where are we? We're walking in the bush. This stage of the gait cycle. Have we been here before? Oh, yeah. I'm going to make this hurt so much you can do nothing else. And I had leg agony, piercing, white, hot, poker pain, screaming up my leg. And what seemed like minutes was probably seconds. Someone stopped to have a look at the snake bite. And there's a nice little scratch from a twig. Now, if there are clinical people in the audience, you would be tempted as a clinician to write down symptom exaggeration behaviour. But I can assure you I was not exaggerating the symptoms. It really, really hurt. It really hurt. The question is not why does this person think it hurts so much? The question is why does this hurt so much? Why does this hurt so much? Because pain does not depend on what's actually happening in the tissues. Pain depends entirely on what the brain thinks is happening in the tissues. And the brain is very capable of incorporating a whole lot of information. For example, supposedly normal healthy volunteers put their head inside what they think is a head stimulator. The pain that they report correlates really nicely with where the knob is on the intensity setting, even though the stimulator is doing nothing at all. So long as they can see the intensity knob and you turn it up, your headache becomes worse. Established data, many experiments, all by this group called, the lead author is Bayer, published over 20 years, very strong data. We did an experiment with supposedly normal healthy volunteers. Now, these people are actually not normal people, and we have to really concede that our data relate to a small group of people who are willing to participate in pain experiments. Invariably students who are impoverished or drug addicts. But aside from that little caveat, we put a very cold piece of metal on the back of their hand. And as the metal touched their skin, we showed them either a red light. We didn't say anything, we just said, tell us what you're feeling. There are a range of questions that we asked them. They either had a red light shown to them or a blue light shown to them. we asked them all about the pressure and the temperature and all this sort of stuff, but the information that's key here is that if they saw a red light, it hurt more than if they saw a blue light. And for some people, it hurt, instead of 2 out of 10, it hurt 8 out of 10. There's nothing different about what's happening at the tissues. The difference is the brain making a decision. The brain evaluating, okay, how dangerous is this really? What can I call on? Hang on, it's a red light. Red light means hot. This is highly dangerous for your skin. How am I going to prevent you from being damaged? Ultimately, I would argue, how am I going to sustain you in the gene pool? I'm going to make this really hurt. And that's exactly what happens. Part of my role, and something I take very seriously, is teaching patients with chronic pain about their chronic pain. And that's a very difficult thing to broach, the possibility that their pain may not accurately reflect their tissues. Because the stigma of pain is such that, well, if there's nothing on MRI or X-ray, you must be making it up. That's a biologically corrupt perspective. You cannot defend that perspective on biological grounds. You have to defend it on some quasi-workers' compensation informed view. I don't want to make any apologies for that strong view. But let's just talk about vision, which doesn't have the stigma. Most of us see. This is how vision works, okay? My dad's been asking for a long time, can you put me on one of your slides? So the vision comes, the light comes into the eye, hits your retina, goes to the back of the brain where there are a billion brain cells that supposedly flip the image so you can see what's hitting your retina. I had a school teacher, ironically called Mrs. Smart, when I was at school, and I asked her about this. I said, wouldn't it be more sensible if we've got a billion brain cells that are just flipping an image to just put another retina there? And then all we'd need is just a little retina at the back of the brain, and we could use all of those brain cells to think with. And she looked at me and she said, young man, we are fearfully and wonderfully made. And I thought, that's it. Previously I had a crush on her daughter, and the crush vanished. Possibly a gene pool related thing as well. But however, now I look back on that, however many years later, and I think, jeepers, how many times do I now think, oh, we are fearfully and wonderfully complex. We really are. This is not how vision works. It's not just a case of flipping the image, and I'll prove it to you with vision. So when you look at this, if you look, there's one square that's got the letter A on it, one that's got the letter B, and then we would hopefully, in fact, raise your hand if you see square A to be darker than square B. Fantastic. There's a few of you with a very embarrassing neurological disorder, or you've had bilateral arm amputations, and I apologise for that insensitivity. Look what happens if we will reproduce those two things there. A and B are actually identical, but you don't see it like that. But look at what happens if you turn your head on the side. Nothing. There you go. But look what happens now. We're going to move A onto the A square, and we're going to move B onto the B square. And then we're going to move A over onto the B square. Just watch that go over there, and look, they're clearly identical. We'll move B back up to the A square. Clearly identical. This is not a PowerPoint trick. What you're seeing is not what's hitting your retina. What's really happening? Well, these two identical shades of grey hits your retina, goes to the back of the brain, sure, but then a whole lot of groovy stuff happens. And it happens so quickly. And you don't know what's happening. It's instantaneous. Effectively, the brain is recruiting everything it knows. What does this mean? What will be advantageous to me right now? Same thing happens with pain. So for those of you who don't know much about musculoskeletal stuff, this is not a normal situation for this man. Something dangerous is happening in his right leg. And his brain has to ask the question, what does this really mean? How advantageous is this? And hopefully the brain will make his leg hurt. And therein is the drum. Therein is the rub. There is the rub drum. The drum rubbing bit is that pain is an output of the brain. It does not exist until it exists. It doesn't exist in your body, never does. It's a production of your brain. It's all about meaning. This is how one fellow coped with his shark attack amputation. It's all about meaning. So how does it happen? Well, pain emerges with activation of a thing we call a neurotag, which is a network of neurons. And we can say, okay, there's the network of neurons, and when you activate them all together, bang! Very conveniently timed sneeze, whoever that was. Bang! There's pain. And these neurotags, which are networks of neurons, share brain cells with each other. That's how we're so efficient as a brain, if you like. For example, if we focus on this particular brain cell, which is part of the pain neurotag, and I call it a neurotag because it's like a signature, like a graffiti artist has a signature. It's like that, this network of neurons. It's different in all of us, and it's different for different pains. But the brain cell that I've circled there might also be involved in the representation in your brain of beliefs about your back. Let's say this is the back pain neurotag, and this is the beliefs about your back. If you think your back is a fragile, easily breakable, slipped discable sort of a thing, then that brain cell will have a role not in just representing that, but in just increasing the excitability of the back pain neurotag. It might also share brain cells with thoughts and feelings about your back. Expectations about what this means. Well, Aunt Martha fell over in the supermarket and she ended up in a wheelchair. I've just fallen over in the supermarket. And it was interesting looking at Jeffrey's lovely presentation and seeing the slide of thinking errors. And you could apply all of those to the patients that I see with chronic pain at different times. Catastrophic interpretations. This will never get better. Any credible evidence of danger to your body will manipulate this. And if there are any musculoskeletal physios or doctors here, I know that you will have one of these models. Just think what's happening inside the brain of a patient with back pain when they walk past your desk. And they see an intervertebral disc sitting on the desk having slipped right out of the spinal column. And the good thing about these models is that you can have a left-sided slip or a right-sided slip, and you could pick that up and just throw the disc across the room. Clearly don't bend over, because if you do, it might just hit the person behind you. Any credible evidence, the look on your face as a clinician when your patient tells you the story, or the favourite from orthopaedic surgeons. It was a real mess in there, but I think I've cleaned it up. You've got the knees of a 75-year-old. Shit, I thought they were mine. What happens in the brain when pain persists? Well, lots of things happen in the brain, and we've heard the theme already in these 2 days. Neurons that fire together, wire together. So there's 2 things that happen in the brain. One is that this neurotag that produces pain becomes more sensitive. We know that if you have back pain for 25 years, and there are many people who have back pain for 25 years, watching someone else pick up a box makes your back hurt. And we do a brain scan and we can see that you're not lying. You don't just think it hurts. If you think it hurts, it does hurt. So over time, this network just becomes stronger and stronger. And Jeff's already talked about these ideas of habits. And there is a very compelling argument to say that pleasure and pain share a lot of the same neurology. We did a very interesting experiment when I was in the UK where we got sadomasochists, and we looked at their brain activity in 2 different situations when we put a hot poker on their leg. One situation was me on a recording saying, "And now I'm putting the hot poker on your leg. Can you feel it?" Yada, yada, yada. And the other was exactly the same script read by a mistress. And the brain activation was similar but slightly different in one key area. But the experience moved from pain to pleasure. Now, these people don't find pain pleasurable. They find noxious stimuli in that context pleasurable. They're not hurting because they're in pleasure. That's the distinction between pain and tissue damage, or nociception is what we call it. So when pain persists, we get increased sensitivity. We also get decreased precision, and that's a real issue. Normally, these brain cells want to be activated in a very precise fashion, and that gives us a very precise output. When my son, Lord Adorable Squeaky Pants, which is not his real name, was learning to say the word isosceles, it was a great example of the brain learning how to inhibit unwanted brain activity. Because for a long time he could not say it, he would say allosceles, isosceles, drum rubber. He couldn't get it. And the problem with that is that he probably had the constituent brain cells, but he could not inhibit the extra ones that were also firing. Until one day when he got it. We were driving in the car and I said, have a look at that shape up there, Gubs. What do you call that? He looks at it and he says, oh, it's a triangle. What sort of triangle is it? Isosceles? I get goosebumps remembering that time. The look of satisfaction on his face. It was a rectangle. When we have pain for a long time, this effect of reduced precision is that the pain starts to spread. So here you can see I've circled some green brain cells that are activated now whenever that neurotag is activated. And if those brain cells are in a part of the brain that represents your body, for example, primary sensory cortex, now the pain is spreading, or it's moving, or it's changing. And if we don't understand the complexity of pain and the plasticity, the changeability of the brain, then we would have to conclude the body is becoming more damaged. And that's an erroneous conclusion. So we need to reconceptualise what we understand chronic pain to be. What do we do about it? Well, much of my research is really trying to address this question. And I'm emphatic about this, that people need to understand that their pain is 100% real. It's unpleasant, it's horrible, it's debilitating. But it is no longer an accurate indication of the state of the body because the system has changed. We do a lot of work teaching people how to get under the radar system of a very sensitive nervous system that's on the lookout to protect them. We can use tricks to help convince the brain that things are different. Here's an example of that. We did an experiment with people with a condition called reflex sympathetic dystrophy or complex regional pain syndrome. They have a very painful hand and they do all these hand movements, and when they look at their hand during the movement, their pain gets worse and their swelling gets worse. And they look through two little tubes like a magnifying glass, and as my daughter, Princess Petunia Cake features, not her real name, would say, well, that's hardly rocket surgery. Nothing changes. However, if you look at it through a magnifying glass, the increase in pain is magnified. They're not doing anything different. The increase in swelling is bigger. So the hand is doing exactly the same thing. It's the influence of the brain's perception of the hand. The groovy finding of this study is that one there, that when we turned the binoculars upside down, the increase in pain was drastically reduced and the increase in swelling was reduced. The cool thing, I guess, the area that excites me at the moment is that we can retrain the brain to regain precision. And we're getting good symptomatic and functional advantages. We don't solve the problem, it's not as simple as that. But we're starting to make gains now that we couldn't before. I'd like to thank you very much for having me, to the organisers for having me, but also go to Movember and either sponsor me for this thing that I'm doing with Courage or someone else, because it's a great cause. Thanks for having me. Thank you.